And as we discussed amongst ourselves, we are really grateful to Dr. Ranjeet and to give the background for the international speakers. And this is a 20 almost 20 years old organizations. We started our journey in 1999, and we work with the principle of United Nations. That means we have got one branch, or we call country chapter, in all countries. Like that, we have our country chapter from 19 countries, and it starts from Turkey to China. It's a Greater Asia, including Central Asia's countries. And one of our speaker is also from Central Asia, and she is Dr. Maya, and she's presenting the componentizations as well as plasma fractionation in Uzbekistan. And having saying that, plasma fractionation, because there are experts like Leni, then the experts from Efantis, and you know better about the global scenario, including Dr. Ranjeet. However, lots to do for developing country like India. Not only India, AATM member countries, to be precise, because first we have to develop the component preparation to the optimum. Most of the countries in this part of this world, we go by the whole blood, at least not talking about that source plasma. It is mainly recovered plasma, and that is also not 100%. So we need assistance from the expert like PPTA, IFPA, so that we can develop this program, global program, and ultimately resource utilizations from this precious human resource. I will not take much time, and to give a background how this webinar came up, because we have got working groups. It is like ISBT, they have got working party, and this working group, one of the working group is plasma protein therapy, and Dr. Ranjeet is a part. And after our discussions, it came up, why not to go for a global webinar? And again, I am saying thanks to Dr. Ranjeet, and let this activity not finish, or we do not finish after 2 hours. Let it be a continuous activity, so that we can develop this plasma fractionation as well as component preparations amongst our member countries, and we can source plasma and utilize plasma. I will now request Dr. Ranjeet to take over, and thanks for also giving me the chance to address you in the beginning. Thank you very much.
Thanks, Dr. Nabajyoti. It has been a pleasure to work with the entire team over here. And I guess this seminar brings people from across the globe, from the US, from Finland, from Turkey, from Uzbekistan, from India. So this looks pretty international in sense of its a presence. And I'm really thankful to everyone over here, especially Emmy, Leni, Nuri, and Maya, those who have joined from far off places and on such a short notice. So I'm really sincerely thankful and appreciate your consideration. Having said that, I think I would say to start the work, let's hear from Leni, what she has to offer us from the European perspective, how the recovered plasma and how it can help in making the plasma product medicines. And Leni holds a doctorate degree, and she has worked with the Finnish Red Cross, and most of her career is into the plasma products. So I'm sure, her learnings would be great for all of us. So thank you, Leni, and over to you.
Okay, thank you very much, Ranjeet, and it's a pleasure to be here and speak to you all in this webinar. And thank you for your kind introduction and asking me to join this meeting, because I represent IPFA here, and this is really a new role for me. As Ranjeet told, I used to work for the Finnish Red Cross Blood Service a long time ago, and I've been involved in almost all the processes of plasma production and fractionation. The last 10 years, I was managing director of a sales subsidiary of Sanquin in Finland, selling plasma products locally in Finland. So my position now at IPFA is really very new. I started last November, so this is one of my first performances. So bear with me if I'm not very used to telling you about these subjects, but I think my speech will be more an introduction into the whole area, and I hope you will get something out of it, even if I'm sure some of you know very much of the things I will talk about, but maybe as a beginning you will learn something. Just first to tell you a little about what is IPFA. IPFA is an association for not-for-profit organizations in the plasma world. We represent both fractionation companies and also national blood services, both active with the collection of plasma or the making of plasma products. Our members are from all around the world. We have from the United States, South Africa, Australia, New Zealand, and in Asia we also have a member in the Japan Blood Products, who is our Asian contact there. Our office is in the Netherlands, in the premises of Sanquin, who is a member. And I myself, I sit up there, if you can see it. I'm right here up in Lapland for escaping the pandemic for a while. So what do we do here? We support at IPFA. We want to support our members really in their goal to ensure that they have access and availability of life-saving plasma-derived products, which I'm going to refer to as PDMPs through this whole presentation. And the speciality of IPFA is that we really recognize plasma as a strategic source. I'm sure it will be discussed later in this presentation series that plasma is scarce in the world, and we need all to provide a better source of plasma. And at IPFA, we especially promote the voluntary unpaid donors for the collection of plasma as well as blood. Sorry, next slide. At IPFA, I will not go through all the details, but we really work a lot with competent authorities. We contribute to international regulations, and we do a lot of partnering with other stakeholders, including patient organizations. And like in this webinar, we support ways to establish contract fractionation for developing countries. This has been a long-term work also for IPFA. And we really think that science should be the basis for decision making. So we have a strong base of scientific knowledge and background in IPFA. You may know IPFA from their workshop, which have been going on in the past for many, many years. One of them is about surveillance and screening of bloodborne pathogens, the so-called virus meeting. And I'm glad to tell you that we are really working hard on setting up the next meeting as a virtual one this year. Last one, it was cancelled due to the pandemic. The same goes for regional workshops on plasma quality and supply. I hope we can arrange one soon again. But coming to today's topic, plasma, the yellow liquid. As you are representing the transfusion field, I really want to stress that what we are talking about now is not the plasma for transfusion, which you collect from your blood donors and provide in the form of fresh frozen plasma, or maybe as virus-reduced plasma in some form. There is even more like a product called solvent detergent virus-reduced plasma, which is made out of pooled plasma from several donors. So this is the uses of plasma directly in the hospitals in a frozen form. But today we will talk about the plasma for fractionation, and that is the plasma that you use for making plasma-derived medicines. It can be either recovered plasma, the plasma that is taken out from the whole blood collections, or it can be source plasma, which is collected through apheresis, which is especially collected only to make plasma for fractionation. So the topic of today is, as I discussed with Ranjeet when I prepared this, is really on the recovered plasma, which is what your blood establishments is collecting and have as a raw material. So what are the plasma medicines, the PDMPs? Well, they are plasma proteins because plasma contains hundreds of proteins. And plasma medicines are purified from plasma and concentrated into pharmaceutical medicines. So the typical speciality of plasma products is that they, in contrast to blood products, they can be stored at room temperature or cold, let's say refrigerator temperature, and for a long period of time. It makes them much more usable in a long term than a blood product that has to be used within a short period of time. And also, what is of course very important is that they have to be registered and approved according to legislation. They need to have a marketing authorization approval. A typical thing that may not all people who are not in this field know is that they are actually part of the biological medicines. Or some people might think that biological medicines are the ones that you produce through recombinant techniques, but it's not only so, also plasma products are really biologicals. And a special thing about them is that most of them, as they are blood proteins, they also need to be given to the patient through IV administration. It can be also subcutaneous or intramuscular, but the normal route is intravenous administration. So it's not a pill you go and buy in the pharmacy as such. It needs also careful administration. And what are they used for? Well, I think the most important thing with the PDMPs is they are really life-saving medicines. And it's still in these days when we have so sophisticated ways of making medicines, like we now have seen with the new vaccines coming out from the pandemic, these plasma medicines are still needed and they cannot be easily replaced. There are not always ways to make a certain plasma product in another way. And alternative therapies either not exist at all, they are very few or very expensive or just coming up. So we really need plasma-derived medicines still for a long time. Also special for them is of course that they require specialists for prescription and use. It's not for not normally any GP that can prescribe them and give a recipe in the hand of the patient. They are more part of a bigger treatment and of specialist treatment and in hospitals and in that kind of settings. So the main therapeutic areas and the proteins from plasma for these areas. Of course, the rare diseases. And here you have to recognize the coagulation factors, which are used for hemophilia A, hemophilia B, von Willebrand disease, and other bleeding disorders. And these are really, as you can imagine, if a patient is lacking this protein in his blood, he cannot live without it. So it's not that easy you can really understand that they are life-saving. The other rare disease group is really forming together a large use and is the biggest use of plasma-derived medicines at the moment is the IgGs, which for the immunodeficiency, which is a rare or many rare disorders taken together. And also, I'm sorry if my dogs are barking. And certain neurological disorders. when the IgGs function more in the form of immune modulation. And also there are some hematological conditions. Very important, and actually the basis for the plasma products in the historical view is the intensive emergency care in hospitals, where we still use a lot of albumin as a fluid volume replacement. Albumin is really a very good and the best natural colloid still available worldwide. And we have something called prothrombin complex concentrate for certain reversal of blood thinners like warfarin. In the developing countries, the infections, diseases, and the use for prevention of treatment of many viruses, for example, is really important, especially if there is not a highly vaccinated population and you need very emergent care. These are in the world of plasma medicines, rather small medicines, but they are still essential and really can be life-saving for that patient who has received an infection. So a little bit how to produce PDMPs. This is something I could talk about for a very long time, but this is making it short. You start with a plasma for fractionation, which comes from the blood collection units. It's frozen in bags, and that plasma goes into the production, which in the world of plasma medicines is always called fractionation. It comes from the old method developed by Edwin Kohn around the time of the Second World War, where the plasma was divided into fractions, and each fraction contained a certain group of proteins. And the last fraction, fraction 5, is actually albumin, the target at that point. And from that you make the final products, which are put into glass ampoules mostly, and they have to be in very high strict hygiene circumstances for filling. So what makes this method so special? Plasma is really a unique raw material. It's from many human beings, and you combine many units of individual donations in one starting pool of plasma fractionation. So it means that every batch of plasma is a mixture of many persons' plasma, which is combined in a large pool. So there's always variation from small variations from batch to batch, depending on, like we people also vary between each other. The manufacturing process is complex, and what is also special for it is really stringent hygiene and GMP requirements. You can imagine that the plasma as a biological material would be wonderful for bacteria to grow in if you are not doing it in a very hygienic way in closed containers and keeping the temperature, etc. Plus all the GMP rules you have to have for this type of high standard manufacturing process. And the final products, of course, for plasma, the special thing is that you can make many different products out of the same plasma pool. And this is really important for the economics of the whole plasma fractionation. The more products you can make from one pool and use is also making the economics of the whole process much better, because you have several products that you can share the costs of the manufacturing on them. In today's world, IgG is really the driver, and sometimes even might be the only product taken out of a certain plasma pool. And in the long term, that's a pity, because there are many proteins that could be needed for other reasons as well. So some pictures from the fractionation process. It starts here up in the left corner where plasma is coming in and the bag is cut. And each one of these units is put into large tanks, thousands of liters, combining thousands and tens of thousands of donors' plasma. And this is, of course, as you can see, high-tech manufacturing in very special environments. You use, for example, for purification, chromatographic processes like here, and sometimes you have the joy of seeing the nice blue protein, it's called keruroplasmin, which is found in plasma, and you can see the nice colors of plasma in it if you are lucky. In the end, we can see here a certain step that is dedicated for virus removal. PDMPs, as you know, they are really important that you have a very high safety measures from infectious agents. It's a unique raw material, and this is from history, as we know, with the past of the HIV scandals, etc., which when at the time we didn't know how the virus spread through the products, caused big sorrow for patients. Today we can do it in a very good way, and we can keep the product safe. But the risk is because unlike blood donations where you give more or less from one patient, from one donor to one patient, in plasma you combine everything in large pools. So one infection can affect a large number of other plasma donations in the same pool. So obviously you need to have the same donor testing of known blood-borne viruses in place. And in addition to this, to minimize the risk of any further transmission, the production has to include several different types of methods to inactivate or remove any blood-borne virus. And today there are many robust and consistent methods available, and we have good records that these are really working in ensuring that no transmissions come through blood products. Here I show two of the most, in my opinion, most important and safest method that we have currently to remove viruses. One is through it's called nanofiltration, where viruses are removed by size. So the filter here represented by these small holes can only pass the proteins you want, and the viruses, depending on size, remain on the other side. As a curiosity, I can tell you that the coronavirus is about 100 nanometer large. So if for some reason it would be in the plasma pool, it would be nicely stuck on the side of the filter. And these are pictures of how the hollow fiber filters look. The other method, which is also widely used, is the solvent detergent method, where a solvent and a detergent dissolves the outer lipid layer of the virus. And I think all of you have been using alcohol and soap on your hands for the last year, and this is exactly the same method that is used in the plasma process to dissolve these lipid enveloped viruses. So, to your question, how can you go ahead with utilizing your recovered plasma? Well, I understand you represent a large, wide area of countries and nations, so I cannot address you all. Some of you are further in the process, some of you may be starting. But it's really important to stress that you have to know what's your overall plan and motive. Do you need more products to your country? Do you need to have a better control of your plasma in your country, that you want to sustain a more strategic way of having your access to plasma-derived countries? How many plasma, what kind of plasma products do you need in your country? Do you need to have for hemophilia? Do you need IgG? Do you have some specific rare disease you want to meet? And also one thing you have to consider, how much plasma can you provide? Are you a small unit, only can provide thousands of liters, or do you go up to hundreds of thousands of liters of plasma that you would collect in a year? Also, this puts a different possibility for you how you can go ahead. And always in the plasma business, which is a very, let's say, slow and an industry where you have to plan far ahead. So you have to plan for many years ahead normally, and you would have to have a long and sustainable collection perspective to be able to continue over the years. Otherwise, any investment in setting up systems will not be useful. And what I put here at the bottom is really, is your quality and GMP framework fulfilling the requirements set for plasmafractionation? So, well, how can you use your plasma, recovered plasma? If we start with that, I put in brackets right quality. So I think somebody's sound is on. Well, you can do the easiest way is to supply plasma to somebody, a foreign fractionator, who approves your plasma, and you might import PDMPs from the same fractionator or from some other fractionator. So there is no link to the plasma you provide and the products you import. So I wouldn't really say that this is a very sustainable and long-term method. At least you don't have much control of your own plasma. So the second step is more what we seek for at IPFA, which gives you more strategic independence, is either setting up contract manufacturing bullet 2 or set up really a local manufacturing using your domestic plasma. So the number 2 is easier done if you have, let's say, medium amount of plasma available, not many hundred thousands of liters, and you can come to a deal with probably a fractionator outside of your country to do it. To set up local manufacturing, you really need the large volumes, several hundreds of thousands of liters plasma available for a long time period, very good long commitment. It requires high investments in a plant and the technical skills, infrastructure, regulatory knowledge, etc. Of course, this is a very good way of reaching strategic independence for plasma products. And again, I stress this, there needs to be assurance that your plasma and its collection follow the quality and GMP requirements for plasma for fractionation. I'm coming to the end of my talk here, so only some points to consider on regulatory aspects for national authorities on contract manufacturing. You have, as a plasma supplier, know that your plasma collection has to be approved by the regulator of the country of the fractionator, and you have to do the collection according to the contract with the fractionator. So you really get to be involved with the fractionator at an early phase when you set up your quality system. And for the foreign fractionator also has to approve that your plasma is taken into the country. Obviously, the national authorities are required. You need to have the registration in your country, and as I said, the approval of the plasma in the country also for the fractionation. So my conclusion is that recovered plasma from blood donations can be used to make many and very important life-saving medicines. And really, for you to remember, the production has 2 specific features. It's a very unique raw material, and there is a very complex production process to understand before you start anything on it. And really the prerequisite for everything is that your quality and regulatory aspects are in place before you even start really going into the deep thinking of how to do manufacturing your PDMPs. So this is what I wanted to tell to you today. And thank you very much for your attention. And you can always contact us at IPFA if you need more information. Thank you.
Thank you, Leni, for a very elegant presentation. It was really very good to hear you from the recovered plasma perspective and how important it is for the countries to ramp up the recovered plasma collection program, because every drop of the blood counts and every drop of the plasma counts when it comes to the patient and use of the blood and plasma component. So it was really very elaborative and very good. So thank you very much, Leni. And we will take question towards the end of the, when all the speakers have, expressed their point of views. So that would be good. I am getting message from Maya. Is Maya, are you able to hear us? Okay, I think we'll try to fix Maya's mic, but Nuri, are you able to hear us?
Yes, I can hear you. I can hear you.
But how about your presentation? Are you able to project the presentation?
I sent the presentation to you and I suggested you are going to put it on the screen.
Yeah, I can put it, but will you be able to present it then? Are you able to see the screen?
Yes, I can see it.
So let me pull up your presentation. Okay.
Thank you.
Thank you. Just give me a second.
Okay.
How to minimize it? This one. Yeah, need to share this screen. Yeah. Yeah. This one?
Yes.
Yeah, Nuri, go ahead.
Okay, just let me make it a full. Okay, thank you.
Yeah,
so, sure. Dear President and distinguished colleagues, friends who are already on the group now, it's my pleasure to share our experiences with you. And we have, let's start. How can I go further?
I can go for you, Nuri.
Yes. First of all, I want to pay a great appreciation and respect to Dr. Edwin Cohn and the other scientists who contributed for the very sophisticated life-saving technology in the world. As Dr. Leni said, that it was started during the Second World War time, but till that time, it has progressed and came today. Next slide, please. Ranjeet, can I go by myself here?
I think no, you can't, because I am sharing your screen.
Okay, thank you. So, Turkish Red Crescent had an experience of a kind of plasma fractionation products between the years of 1969 and 2002. Those are the photos of those days, purification and fractionation equipments. Those equipments were donated by German Red Cross to Turkish Red Crescent, and it started to produce factor 8 intramuscular immunoglobulin, dry plasma, and some sort of products, but those are not, as you know, that those are not the real plasma medicinal products like we are talking today. But those products had so much to save the lives of the patients on those days. Next slide, please. Now, in 1990s, as Dr. Leni said that, due to the HIV scandal in plasma products, mainly for the factor products, till 1990s, some of us can remember that most of the large-scale blood centers were also producing so-called plasma products. without virus inactivation, without high purification. Since 1991, it continued. When I first visited 1990 Groningen, I met a lot of blood centers promoting their plasma products. But after 1991, all were stopped. And industrial plasma products became very popular in the market, and many producers had a great success and take the market. In those days, Turkey started to talk about self-sufficiency in plasma products, because those days, like even more than today, the prices of the plasma products were high, very high. It's not so easy to find, and it's not too easy to cover those expenses. So this, at the right side, you see the cover page of quarterly newsletter of Turkish Blood Bank Society journal, which is called Damla, means drop. It was the first page, cover page says that Turkish Red Crescent is going to establish plasma fractionation plant in Turkey. That article was written by those days Turkish Red Crescent president, Dr. Ertan Gören, and respect to him, he passed away. So since 1996, Turkey is going to have a self-sufficiency in plasma products. Next slide, please. Self-sufficient strategies. So, as Leni also pointed out, if you want to be self-sufficient, either if you are capable, like some small rich countries, you can directly import it, or if you have enough plasma, you will start with toll fractionation, then calculate your capabilities and your sources, then you can go for the second step, plasma fractionation plant. Or if you have a very strong background and experience and finance, you may directly go to plasma fractionation plant at your country. Next slide, please. What is for having a plasma means you need a blood banking system, an organization in the country. In Turkey, Ministry of Health is the main body to coordinate all health issues in Turkey, as blood banking field also. Since 2005, Turkey had a hospital-based blood banking, but in 2005, Ministry of Health appointed Turkish Red Crescent as the main blood supplier of the nation, and Turkish Red Crescent started to reorganize itself for properly complying this service. Now, Turkish Red and Turkey switched to regional blood center system. Now, Turkish Red Crescent has around 4,000 personnel, and they are running already 18 regional blood centers. They have 67 blood donation centers. Blood donation centers just accept the blood donation without making any action on the donated blood. And they have central screening laboratories in 4 different places of Turkey. We call temporary regional blood centers means there are around 11, I think it's now 10, university hospitals which has huge blood centers, and they can supply their blood need. And just to give a time, Turkish Red Crescent to improve their collection level to cover the need of those regional blood centers means the university hospitals. At the down, you can see the number of the hospitals, which is around more than 1,000, and they have hospital transfusion centers. Hospital transfusion centers are eligible to make blood group typing of the patients and antibody screening and Coombs testing. Next slide, please. What is the administrative and legal structure of blood banking in Turkey? Since 1981, we did not have any appropriate regulations. At 1981, we had the first Blood Act, but it should be renovated, and it was renovated in 2007. And 2008, we issued the actual blood and blood products bylaw, and then we proceeded a step more. We established our national blood banking and transfusion guidelines and national blood banking and transfusion standards. Now, Turkey has guidelines and standards. This is so important to go further while talking with the clinicians, while talking with the officials of the hospitals, while talking with the blood provider of Turkish Red Crescent. Why? Because if you ask something in right quality, now you have a clear evidence to show that they have to obey. In the past, we did not have this. When we ask something, our officials or the others say that, okay, you ask this, but who is pushing us? Is it a must? It is an extra money. Now, this is a must and they have to obey. Otherwise, something will happen. They will have a real legal responsibility. Please go further. And also this organization helped us, Turkish Red Crescent, to improve their quality and start to produce plasma, recovered plasma for fractionation. When we look at the blood banking in Turkey, as I told you before, when you look where Turkish Red Crescent came from, in 2005, they could only collect annually 342,000. Now, in 2020, under the stress of the pandemic, now they could collect almost 3 million units. They already have 10 million, 11 million registered blood donors, and 54% of those donors are repeating donors. And you see the regional blood centers of Turkish Red Crescent all over the Turkey. Please, next slide. Okay, so what is the annual plasma product demand of Turkey? While talking about the plasma products, yes, there are so many niche products are available from the plasma, but we have a common 4 plasma products in the world market. Even there are some recombinant competitors of them. When we started talking about self-sufficiency in Turkey, 1994, 1996, the leader of the product was the factor VIII. Now, in Turkey, IVIG is the leader of the plasma fractionation. Annual need of Turkey is around 1,000 kilogram of IVIG, around 16,400 kilogram of albumin, and around almost 500 million units of factor VIII, and almost 50 million units of factor IX. In Turkey, plasma products field has been dominated by the hemophilia group. Hemophiliac families, and mainly the doctors, hematologists who are dealing with the hemophilia, they were really very respectful persons, and scientists, they pushed the market, they pushed the government, even they motivated the families to come together and establish a social power on the officials to comply their demand. Turkey is one of the countries which is providing the prophylactic factor VIII treatment for the patients. Next slide, please. What is the fresh frozen plasma source of Turkey? As you saw, the final annual blood collection of Turkish Red Crescent, which is around 3 million units, and around 10% can be collected by the other temporary regional blood centers, means university blood centers. So we have around 3,300,000 units of blood collection. And we can ignore part of them for the positive tests, problems, distractions, fresh frozen plasma transfusions, but we can provide 500,000 liter. I think I missed to put 10 here. 500,000 liter recovered plasma per year. It could be over, but I don't believe that it would be less. On the other side, source plasma can be considered in the future like the other countries. Yes, as you know that, there is a saying in philosophy, each unfortunate can take also some fortunate. This bloody pandemic gave a kind of support to blood banking field, in my opinion. For example, because of the hyperimmune plasma, now people are more close to donate plasma. Public has a better understanding about the importance of the plasma. And in the future, and also all around the world, people understood that globalization can be something, but globalization can be a kind of threat for the future of the countries. You know that the main plasma supplier for production is United States. If something will happen, I don't know what will be the next year. If the number of the source plasma will decrease in United States, how can the other countries, other fractionators find a fresh frozen plasma for fractionation? On the other hand, this is a high, unacceptable irony. Countries who has fresh frozen plasma from the recovered plasma, because of some other reasons, mainly the political and official suspicions or the hesitations, we threw all those plasma to the biologic waste. On the other hand, we need products. Now, till today, industry can be happy that they are selling their products, supplying their fresh frozen plasma by United States, but now they are going to have a short of source, so they cannot. So the countries may not have enough plasma products, so they should consider their recovered plasma as a source of their plasma products supply. Otherwise, they will have a great problem. Next slide, please. So, essentials of self-sufficiency in plasma products. I'm going to, I already started to write a short article or a kind of letter to editor about our experience in Turkey for self-sufficiency in plasma products. I am one of the first person started on this idea and voluntarily worked on this subject. When I started, I did not have a son. Now my son is 25 years old, but still we do not have the plant. We are not still self-sufficient. It is a kind of endless love. I hope this endless love will come to a final end and happy marriage. I don't know, but we can see it. So what the countries should do? First of all, we have to be realistic. First of all, create the annual fresh frozen plasma source. Then decide the strategy, toll fractionation continuously or toll fractionation for a certain period, how long and how, then a kind of plant. What kind of a plant? What will be the size of the plant? What will be the purpose of that plant? Importing, exporting also, just for the domestic, or both of them. On the other side, define the responsibilities and rights of the parties. In Turkey, we, at the beginning, at first step, we made a great mistake. Those days, a lot of producers are so much willing to be in this project, and we accepted ourselves like a celebrity. We said that we want this, we want that, we want also the other one, etc. Those were not realistic. So we had to put the responsibilities and right of the parties. What will be the private company will do if it will not comply this one? What will be the punishment? So what will be the punishment? How effective will be the punishment? How realistic will be the punishment? So those are so important. While you are working on this field, there should be a very well experienced, how can I say, attorney group in this project. Please continue. Who knows the international law and who knows the national law? What is the self-sufficiency road of Turkey? Turkish Ministry of Health, as I said before, is the main decision maker and the owner of the health services in Turkey. They say that Turkish, for self-sufficiency, they made a kind of tender, and at the end they pointed out a company for manufacturer. And they attended Turkish Crescent as a fresh frozen provider, and they negotiated with Social Security Organization of Turkey, means the governmental health insurance, purchased Turkish products first, and then, if there will be a need, make the exportation. So they give a guarantee to the manufacturer to purchase a certain guaranteed amount of plasma products. Next slide, please. Biotest Germany has chosen as a technology provider company in the world, 2016, and it will start with the toll fractionation. So, okay, starting the toll fractionation. It is not something, okay, let's go to Germany today. To make your plasma available to enter the German territory for fractionation, as all of you know, that it should comply some standards. It should comply some regulations. For this, Turkish Red Crescent started to reorganize its plasma collection and storage system from the beginning till the final. That is why, after they will complete all those procedures, Turkish recovered plasma can be eligible to be transferred to Germany for toll fractionation in biotest plant. Now, Turkish Red Crescent is going to finish all those efforts, hopefully in 2021, and we hope that the first batch of Turkish fresh frozen plasma will be transferred to Germany for fractionation at Biotest Technology Company. Yes, please, the other slide. So, thanks for your attention and patience. And there are lots to say based on our experiences. But there is a shortage of the time, and if anyone would like to have more, they can easily send me an email, and I will be happy to share what I know. Thanks to all of you.
Thank you, Nuri, for this wonderful talk. We couldn't see your pretty face, unfortunately, which we would have loved to see, but You really painted a picture of how the politics and the plasma and the products get into the way. But unfortunately, we are living in the world and we have to deal with it. And
Ranjit, I want to say something if you don't mind.
please do.
My slides are on your service. Anyone who wants to take my slides, you can share them without any permission.
Without charge, right?
Without charge, yeah, charge can be a coffee when we
Okay.
will meet who is going to take it.
Sure, sure.
Especially for the president. He will pay me the charge.
All right. Thank you. Thank you, Nuri. And I'm so sorry I couldn't introduce you formally, but I'm sure with the kind of experience and the way you have presented, the audience would know that you have a tremendous experience in the field and you were representing Turkey and graduated from Istanbul Medical School. Unfortunately, we have a problem with Uzbekistan. Maya is not able to, hear us off. There's a problem with the mic, and I've been trying to fix it, but somehow, sometimes this technology is really comes as a boon also, but sometimes handicap, and we are not able to connect her. Maybe we'll still trying to figure out if we can do something, but if not, we sincerely apologize. And since it's not happening, I will take the chance to, present my talk now and, share my experience about this. Just give me a second. I'll share my screen. We need to close this. We need to open this. Close. Yeah. We close this. We close this presentation. On the desktop. Yeah. Yeah, it is on the desktop. Yes, I'll show you. Yeah, let's try to open. Yeah. Yeah. Is this visible?
Yes.
All right, thank you.
Yes, yes.
So, traveling from Europe to at the cusp of Europe and Asia, and now coming to Asia. So, plasma protein therapy from the Asian perspective, it may be a little rough ride, but let me take you through this rough ride. Um, the Just a moment. Yeah, so please be here. So Asia is really not a small area. It's a long geography with 49 countries, and it hosts about 60% of the global population with around 4.5 billion people. And it has country like China, most thickly populated country in the world, and least populated country Maldives. And it is a huge contrast, highly developed to underdeveloped countries in this 49 countries. And it also includes fastest developing economies like India, China, Malaysia, And also the scene is pretty varying if you look from the political, social, and economical perspective. So, and all these aspects have a huge impact on the healthcare. And all this, the entire Asian countries, they are very contrasting in sense of its economy. If this is a one form of economy, this is one form of economy. If this is the one residential area, this is another residential area. So it represents a huge contrast, and it is also reflected in the sense of the healthcare. And this is one healthcare facility, and this is another a five-star healthcare facility. So this is the contrast which we see in the Asian countries, and we need to accommodate everyone as far as health is concerned. So what is the health status if you look in the Asian countries? The diseases of developing countries, we do face, like, living apart few countries in Asia like South Korea, Singapore, Japan, but many of the countries, they have the problem of developing countries like tuberculosis, safe drinking water, sanitization, etc., etc. At the same time, because of the fluid economy and a lot of money have come to the pocket, and thanks to all fast food and everything, we have now diseases of developed world like hypertension, diabetes, stress, and whatnot. Rare genetic disorder, unfortunately, in this part of the world is very poorly organized in sense of the patient group, in sense of the policy, in sense of the treatment option. And also, there are innate diseases which are more prevalent in this part of the world. So there's a huge disease burden if you look in the Asian continent, and there's a low rate of diagnosis for most of these diseases. And if you look at the Asian scene as far as the plasma products are concerned, the rate of diagnosis is very, very low. So there's a huge patient pool which remains undiagnosed, and unfortunately, they die the silent death. Like in case of hemophilia, the rate of diagnosis be somewhere between 5 to 10%, PID very, very less than a percent in some of the countries. So these poor diagnosis is one of the major challenge. And there is a very low clinical awareness among the physicians, doctors, hospital. And that's why, like, they use the whole blood usages are very, very high in this part of the world compared to the Western world. The blood collection itself is very low as per the demand, which means there's a gap between demand and supply of blood in this part of the world, and it creates a lot of problems. So there's a limited plasma available for fractionation. And like in India, only 40% of the blood is gets componentized. Otherwise, the 60% is still used as a whole blood. And the scene is still bad in some of the Asian countries, which means first we are low on the collection, and unfortunately, we are really not using it ethically, judiciously to componentize it. And that's why there's a very little plasma available, and a lot of blood is used as a whole blood. And at the same time, even if the plasma is available in some parts in the Asian region, but there's no plasma fractionation capacity, there are hardly any plasma fractionation plant. And as Nuri was saying, and Leni was saying, that the plasma needs to be qualified in order to reach it for the fractionation. And unfortunately, in this part of the world, most of the donors are one-time donors, and they really may not meet the EU GMP norm or US FDA norm for the repeat donor. So the plasma really cannot go for the fractionation, and there is a low fractionation capacity in this part of the world. And of course, the challenge lies with the affordability, because as I said, the socio-economic status in this part of the world is very, very different, and the medical coverage is very low. The public health care policies are really not very well defined at least as far as plasma products are concerned. So most of the time, patients have to buy the plasma product out of pocket expenditure. And this is something, what it does. There are three fundamental factors what I discussed: the diagnosis, availability of the product, and affordability. And this leads to very poor patient care. And this poor patient care has an impact on the life expectancy. And they, most of the time, the patients like hemophilia or PID, they may not be able to lead this very socially active life, and they may not be part of the main social developmental agenda. And this is really shame on the entire system that we are not able to provide them a good quality life, and they remain isolated socially on that account. And the contribution to the society remains from their point of view very little. And I think there's a lot needs to be done for this patient group, because each life is very important, which if it happens to be you. So I think we should work on this agenda, and that is something very, very important. Now, Asia, if you look on sense of the fractionation plant, they are highly concentrated. 3 in Korea, 4 in Japan, about 20 in China. In India, there are 4 fractionation plant, and in Israel too. I am sorry, I have missed one in Thailand also. There is a one fractionation plant in Thailand as well. So this is the plants are really concentrated. Sorry, Thailand is there, yeah. So how about the product availability and the patient care? So the products are available in these countries where the fractionation plants are there. They are plasma derived as well as recombinant. But in case of Japan, there is no export and contract fractionation policy. In case of China, the products other than albumin, no other product can enter Chinese soil. And only one product which can enter Chinese soil is albumin, because the albumin is highly like important product, and they use it very extensively in China. In South Korea, they do allow plasma fractionation, and I have worked on the contract fractionation with South Korea. But lately, because of their own challenges, South Korea is also practically closed for the contract fractionation, and they do export the products in the different geographical location within Asia and outside of Asia. But I would like to say, even Japan, South Korea, the way there is a patient care, let's say for hemophilia and PID, but same is not true in case of China and India, which means the diagnosis remains as one of the very, very important tool. Having product itself does not guarantee a good care. So there is a need of active patient groups in Asia, and we are really not good at it right now. What is the scenario and rest of the Asia? Other than these countries, what I mentioned, the products are important. These products, mostly Asian countries are import dependent, and the product might come from the US, Europe, Australia, China, and South Korea, etc. There's a contract fractionation done by India, Malaysia, Iran, and Singapore. But still the options are very limited for contract fractionation, and the reason could be the capacity of the fractionating company, and also the regulation may not allow the movement of plasma across the borders. There could be a financial consideration, because it's very important to remember eventually the product have to be absorbed by the local economy. So if the contract fractionation fee or the total logistics of fractionation turns out to be very expensive, it's not really viable. And it takes a very long time. The timeline from the time you pick up the plasma and you put the product on the shelf, it is almost 12 months have passed. So it's a quite investment also involved into it, and timeline as well. And of course, this leads to inconsistent availability of plasma product in Asia, and this remains as a regular feature. Sometimes the products are flooded and sometimes products are not available, and it impacts the patient care to the core. And many of the patients, they lose the battle of the life for just not availability of simple products like factor 8, factor 9, etc. So I think there's an urgent need for the local and regional self-sufficiency, because it's very, very important to remember that, as Nuri has mentioned, that, we are too much dependent on certain geographical location, either for the product or for the raw material. And that may not be a right thing. So what is the opportunity in Asia? 60% of the global population, there is better opportunities to live and lead healthy life for these people. That is what we will look for. Improve the transfusion medicine services and rational use of blood, and economic freedom in sense of the region and country is very, very important. So one of the major tasks, is affordability of these products. The products which are produced in the Western world, which may not be really affordable in Asian scene. To give you some perspective, the 1 liter of plasma in the Western world may cost somewhere around $150 to $170, while the similar, I would not use the word same, but the similar plasma probably may cost $40 to $50 in this part of the world. And then the manufacturing cost, logistic cost, HR cost, admin cost, this all makes very, very expensive. See, the products which are made, which are very good quality products and which one would like to use it, but unfortunately cannot be used in this part of the world. There is a poor health coverage, and as I said, most of the time it is out of pocket expenditure. The lower average income is one of the very, very challenging tasks, and these products remain off the patient because they can't afford it. The lack of government support, the healthcare expenditure, the GDP, the social security, etc., is also one of the very important consideration. While doing all this work, the patient support groups are really not very active. It is only very lately in the last, I would say, last 5 to 7 years, the patient groups have really active and they started lobbying with the government, etc. So there is some change. At least I can say in India, I can see the factor 8 tenders, factor 9 tenders, IVIG tenders, but which was not there if I would have been speaking on this forum maybe like 5 years ago. So why fractionation? We have to remember blood is a very, very important human resource, scarce one, and we must make use of every drop of the blood. And there's no substitute as, we need this product, that nothing else. And the optimum use of blood component is not only economic necessity, it is costliest fluid on the earth, but it is a scientific obligation on the scientific community. And the componentization and fractionation is the most efficient way to make use of the blood. And that is the only way we can talk of the self-sufficiency for the reason. And I think that's very important to address. So I think at this moment, Rubik's Cube looks to be quite random, quite chaotic. And this is what our wish would be, to travel here to here. So this chaos and randomness is where we are at this moment. And we would like to see the Rubik's Cube on the bottom of it, which is pretty looking on the very, very well organized. So how do we do that part of the work? So the way ahead is to exploit the local resources ethically and judiciously. There are a lot of young people who could be donating plasma and blood, and we must encourage it. And I would say what Nuri has said, that we must work towards the collection of plasma, source plasma, because we know some of the plasma products can only come from the source plasma, not even from recovered plasma. So we need to develop the regulatory system for collection of recovered plasma, source plasma, and hyperimmune plasma. And movement of this plasma across the region from one country to the other, at this moment, we do face that as a challenge. We actively need to work for setting up the plasma fractionation plant in this part of the world, because even if you have the plasma, but if you do not have the fractionation capacity, still there is a handicap. And then set up more fractionation plant with locally more relevant small countries and send them for the contract fractionation, because small countries like Singapore or Maldives or Bhutan may not be right places to set up a fractionation plant, because they are very capital intensive, they are very complex, and they really don't need it. If they collect 20 or 30,000 or 50,000 liter plasma per annum, the plants are really not sustainable. So we must figure it out, and make a cluster where the plasma can move from these countries and they can get into the toll manufacturing. And develop the patient groups, lobbying with the government. And I think that is the way probably we would be able to move forward. What is next? Create a forum like PPTA, like IPFA in Asia and sub-Asian region to address these issues, because our issues may not be similar to the challenges and the issues which are addressed by PPTA and IPFA. They can certainly help us. They can be a good model to work on it. And I'm sure they will extend all help, but we need to figure out our problem and work towards it, and improve and harmonize the legislative policies and regulatory guidelines across the countries so that we are able to work together. We also need to work in new technologies to optimize the plasma collection and fractionation. We also need to take experience from PPTA, IPFA, World Federation of Hemophilia, WHO, AATM, and others to help us to go forward, and use the better health assessment tool to estimate demand and supply of blood and plasma product. Because at this point in time, we do not have the right estimates. We do not have the patient population data with us. And of course, work with the government and the health policymakers on the Insurance, Reimbursement, Rare Genetic Disorder Act, and Orphan Drug Acts. So the regulatory challenges in sense of registration, market authorization, etc., It's a very long and complex process in this part of the world, which can be done better. Non-clarity on the kind of documents which are required. The language becomes a challenge because, as I said, we are 49 countries, different languages, different culture, and so it also creates a bit of a problem. There are multiple organizations involved in the regulation of blood and plasma product, and the final product testing may not be up to the mark and it needs to be redefined. There is a need to change the pharmacopoeia also in sense of addition, deletion of the methods and the products. The product safety stringent norms have to be set up and recall procedures have to be done, as Nuri has rightly said. And position on the clinical trial and the compatibility trial is really not very clear. And industry representation at various level is very, very important so that the regulatory reform, whatever happens, did help in setting up the plasma industry in this part of the world. I think these are the two books I would say that While 023 is written by Gary William Cross. He's a father of a hemophilic guy who contracted HIV in 80s and 90s and unfortunately passed away at age of in his mid-10 age. And this father has written a very heart-wrenching book, and it speaks how if the responsibilities are not taken by regulator, by blood bankers, by plasma provider, by corporate, what can go wrong? And we all have read and witnessed the tragedy of hemophilic people contracting HIV and other diseases. So I think we must learn the lesson from this particular episode. And the Red Market book written by Scott Kearney. And again, this is a book on the Asia where it is like, the, the, the medical mafia, which is kind of operates in this part of the world. This book talks about the cadaver, sperm donation, surrogacy, blood donation, etc. So I think we must take these learnings very seriously and figure out a better way so that we are able to provide safe and consistent supply of blood and plasma product in Asian zone. Just to create a context, the 15% of the global population, which is in North America and Western Europe, they used about 65 to 70% of the plasma product. But no offense, because the products are available, their policies are in their favor. But unfortunately, if you look other ways, the 30% of the products are available for 85% of the global population. So I think the challenge lies with the regulation, the patient groups, the availability of plasma, and the fractionation capacities. But this is the reality, what Nuri was saying. So this is the really reality. And I think we also have to remember that it is a slide of 2018, where North America, they house only 5% of the global population, but they donate 66% of the global uh, plasma. And this is really, really very, very important. And on one account, one has to really appreciate that the products which are used by globally by patient, the plasma come from the North America. But the political realities are very difficult. And one day, if somebody takes a decision that the plasma which is collected in a geography, the products cannot go from the geography, like in India, if the recovered plasma is collected in India, the product cannot go out of India. So those could be a very, very potentially challenging part. And we must take an account of it and see the Asia, which houses about 70% of the global population, but contributes less than 20% of the plasma. So which means a lot of work needs to be done on ramping up on the recovered plasma collection, maybe on source plasma collection, etc. I think what we also need to see that the plasma which is available in Asia, many of the places it remains unutilized because of the political and regulatory challenges. And this is really not fair. And plasma, is a storehouse of many products like albumin, IVIG, and many specific antibodies. And like for now, convalescent plasma is, and if it is not used, it's a criminal waste, right? Because it is every drop of the blood which is donated must be put to the use. And if it is not used, it's a really criminal waste. There's a huge financial losses which are involved in sense of the making the plasma, storing the plasma, and then eventually destroying it. And then you have to shell out the money to import this plasma products. So I think it will be very important, at least in this context of the Asia, that we must look for recovered plasma utilization and also work towards the source plasma collection. And also we have to remember the plasma is the costliest fluid on this earth, more than petrol. So we must make use of it in the most judicious way. So I think the world is changing very, very fast and nothing is fixed. And I think nothing is carved on the stone and everything keeps changing, and we must change the innovation to grow to better quality of life. That's what we should all aim for. And as I just would like to say that this was the way the movies were shot way back 10, 15, 20 years ago, a huge camera and a crew. And this is a movie, Life of Pi, in which 85% animated tiger and 15% only the live tiger was used. Technically, such a superior film, which means the technology must be used, put to the use for improving the quality of life and any landscape. And I think it's very, very important for us to work towards it. And I think it's very important to remember that patients are patient, whether they are in one part of the geography or on the another part of the geography. And they need this product. And this is a quote from Martin Luther Jr. King, where he says, of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. And we must really consider this. The patients are patient. And if it happens to be you, each life is very important. And we must work towards it. And I think I'm coming to my last slide. And I come from India, where the Buddhist philosophy says there is a cycle in your life and you pay for it. And I think this has happened in India. A hemophilic guy who died in an accident, he was brain dead, and his organs were used in saving 3 other patients. So I think this hemophilic guy who would have received factor 8 from the plasma of so many people in India, eventually, are all over the world, we don't know. And eventually, while saying goodbye to this world, he donated his organs to 3 people and he gave new life to the people. And I think it's so important that all of us do a good deed, and every deed, whatever is possible within us. And I think that's something very, very important. And I think we must work towards the self-sufficiency of plasma product in Asia. And with this, I would like to thank the audience, and I hope you would have liked it. And I would stop sharing my screen. Thank you. All right. So now I have a pleasure to invite Amy, the CEO and President of PPTA. She has been a good friend, and she is going to talk about what PPTA is doing in the field of now the convalescent plasma is happening and a lot of challenges. I'm sure she will bring a lot of rich experience for this forum. So Amy, all to you now.
Thank you, Dr. Ajmani. I appreciate that.
Sure.
I'm going to share my screen.
Sure.
Yeah,
you're there.
Okay. You can see this all right?
Yeah, it's perfect.
All right, very good. Thank you for inviting me today, Dr. Ajmani, and thank you to all the other speakers and to the guests today. It's an honor to be with you. My name is Amy Efantis. I'm the president and CEO of the Plasma Protein Therapeutics Association. PPTA we're a global advocacy and standard setting organization, and we represent the private collectors of source plasma and the producers of plasma-derived therapies throughout the world. Our companies produce more than 80% of the world's source plasma and the majority of the world's safe and effective plasma protein therapies. We're active in areas of global sufficiency, product safety, healthcare advocacy, awareness, standard setting, and of course, donor health. And our mission is to promote the availability of and access to safe and effective plasma protein therapies for patients all over the world. Our global member companies include Biotest, BPL, CSL Behring, Grifols, Kedrion, and Takeda. And I think this is probably something familiar to most of the people on today's call. But plasma protein therapies, of course, rely on the proteins in plasma. And among those, the real workhorses are albumin and, as was mentioned, immune globulins, but also alpha-1 proteinase inhibitor to treat alpha-1 antitrypsin deficiency, C1 esterase inhibitor, which treats Guillain-Barré and other diseases, and then clotting factors that treat bleeding disorders. And I think if there are really two takeaways that I'd like folks to understand, it's that the resource intensity of plasma-derived therapies. So a patient who lives with a primary immune deficiency on average relies on roughly 130 plasma donations a year. If a patient has alpha-1 antitrypsin deficiency and uses a plasma-derived therapy, they rely on 900 donations a year. And of course, for someone living with hemophilia, that's roughly 1,200 donations a year. So the resource intensity is really an important thing to recognize. And then, and I think this is something Dr. Ajmani also mentioned, is just the complex and long process of manufacturing these products. So from the point of collection to the point at which the therapy reaches a patient, or as we sometimes say, from arm to arm, can take 7 to 12 months. So, and I think Dr. Leni also mentioned that, you know, with the resource intensity of this, it's often lay people conflate the complexity of these medicines with sort of small molecule medicines that can be churned out really easily. And of course, these cannot, and that's a very important distinction. I've included this slide because I think that it's really important to drive home the point that's been mentioned a few times on the decline in collections because of the pandemic. So what this slide shows you is over the last decade up and through 2019, you can see there was a very significant and precipitous growth in plasma collections in the US. And in fact, as of last year, there were nearly 900 source plasma collection centers in the US. And that what's really impressive about this is that even in the years of highest collection, so if you look at 2018 and 2019, even in those years, there were challenges to patient access. So in spite of all that beautiful growth, there was still challenges that patient had in accessing medicines. And there's a lot of reasons for that. Some of that has to do with an aging population. Of course, it's good news that patients are living longer with these diseases, but that creates, of course, greater need. Their diagnostics have improved. And so more patients with primary immune deficiency, for example, are being identified. There are more neurological conditions being treated with these medicines, and those diseases are very resource intense, as you all know. And then, of course, there have been great advances in cancer treatments, which has created a need for the treatment of secondary immune deficiencies, which has also taxed these resources. And so I'm sure no one is surprised that all that beautiful growth, of course, was diminished by the pandemic. And we've seen significant drops in plasma collection in the US and in Europe. The recovery in Europe has been a little bit more robust, but certainly because of the rate of the pandemic in the US, that recovery has been more difficult. And that has to do with things like social distancing measures, donors having difficulty because of issues with childcare and work, et cetera. And so PPTA issued this statement because, of course, there is growing concern among patients. So considering that complex manufacturing process for these medicines, as I said, 7 to 12 months, any decline in donations can impact a patient's ability to access these therapies. And that decline in plasma collection currently being experienced could have more significant challenge in the months to come. So that's something, of course, we're watching very carefully. Recently, PPTA has collaborated with the World Health Organization on a paper that is yet to be released, but should be soon, called Increasing the Supplies of Plasma-Derived Medicinal Products in Low and Middle Income Countries Through Fractionation of Domestic Plasma. And one of the takeaways from this paper is that while optimizing the use of recovered plasma is really very important, it's not sufficient to address the growing need for plasma-derived medicinal products or plasma-derived therapies. We've also participated in international meetings, including the Asia-Pacific Society of Immunodeficiency in Chandigarh in 2019. And there, of course, we should highlight the inspiring work of the Postgraduate Institute of Medical Education and Research in Chandigarh. So to contribute to global sufficiency, countries can create environments that are conducive to safe collection and high quality plasma. And of course, that infrastructure is really the first step before any other pieces of this debate can be had. So allowing, PPTA's position is that allowing both the public and private sectors to collect plasma is critical to being able to meet those needs. A deep respect for all donors. Plasma donors should be treated the same way that blood donors are treated. We should increase the efficiency in collection practices, and some of that has already been discussed. Always keeping the needs of the patient in mind and being honest. So by this, we mean managing the expectation of the patient population. And being honest about the availability of product related to the availability of plasma, of course. Increasing or beginning plasmapheresis programs as the primary method to collect plasma for manufacturing. And again, going back to that soon to be released World Health Organization paper, I think this point was made very clearly. Increasing the use of and quality of recovered plasma. And Dr. Ajmani made the point that, you know, there is so much wasted recovered plasma, which is very shameful. And that's something, of course, that should be a big focus. And then a focus on global sufficiency rather than national sufficiency. So one of the things that we always say is that blood is local and plasma is global. And of course, it's intuitive, right? That blood needs to be used locally, but plasma, because of the global infrastructure, it's important that we recognize it as global. For our companies at PPTA, pathogen safety is really the cornerstone of what we do. So this slide represents a sort of tripod, and that includes the selection of donors. So having a rich selection process is really critical. And of course, that's different for different geographies, but that's the first step. And then of course, the testing of donations is very important. And then I think Dr. von Bonsdorff talked thoroughly about the third, but really most important piece of this, which is viral inactivation and removal. So the reduction and clearance of viruses. And she mentioned solvent was and nanofiltration. And for your reference, there was a very good paper that was August of 2020 on nanofiltration by PPT and our member, a number of contributors from member companies. This graphic shows sort of the risk reduction with the processes used by our companies. And in our standards programs, which include the IQPP, which is the International Quality Plasma Program, and the QSEAL, which is the Quality Standard of Excellence Assurance and Leadership Program. Participate in the standards program. And this begins with, of course, donor selection, as I mentioned. The next is the testing of donations and NAT testing. And for our companies, that really focuses on HIV, hepatitis B, and hepatitis C. And then there's an inventory hold period or a look back period, and the dilution of pooling, which again, Dr. Bonsdorff talked about really nicely, and then viral inactivation, and finally, the finished product. So our conclusions are that the need for plasma has never been greater, and I think everyone has really emphasized this point today. This has really been our hallmark over the last year. We applaud efforts by nations to increase plasma collection. We support updating or eliminating outdated regulations and encouraging the coexistence of both the private and public sector to optimize plasma collection. We support science-based decision-making, again, a theme I think that's been echoed by all the speakers. And of course, our member companies are committed to providing safe and effective therapies to all patients who need them. And finally, plasma is a global resource, so the global supply and use of plasma is crucial in determining access to plasma-derived medicines. That's it. Thank you.
Thank you, Emmy. It was really wonderful presentation. You covered the larger umbrella from plasma to the patient and different challenges which we all are facing. We know there's a decline in blood and plasma collection across the globe. And we know the challenges in coming in Q1 and Q2 this year, because whatever the plasma was collected during pre-COVID time probably is going to be over soon, and then we will have real serious problem in time to come. So we must really take it bull by the horn and address the issues and figure out what best we can do. And this was one attempt for us to in Asia to take this discussion forward, and I sincerely appreciate your contribution and insights into this particular part. Now we are open for the question. If any participant has any question, any concern, any suggestion, we are happy to take any question now.
I have a suggestion, Ranjeet.
Yes, Nuri.
First of all, I'm very happy to see the representatives of two major organizations of plasma products in the world. Thank you for both of you, and thank you for your organizations. Based on my personal, I'm just talking as a freelance personal medical doctor who has been in this world longer than 30 years. When I started plasma fractionation topic, Finnish Red Cross was producing plasma products. Dr. Laikola, Koistinen, they were all active, and you were one of the best, and you were helping the African countries. And what I'm telling to you, yes, now we shared an information in this community, which is called in Turkish, exposing the known truth. But we have to go one step further. I suggest with your organization's participation by AATM, we should establish a small core group, and we will make a think tank discussions how we can motivate the local politicians and the officials. That is the key point. Otherwise, I have been listening all those things since 25 years. People all agree, but very few efforts. For this purpose, maybe we will prepare and using this pandemic unfortunate as a fortunate. If the plasma source will not be available in US, how people can find plasma products? So what we can do, we will think together. For example, we had different unfortunate or unlucky stories like Iran. They started before us, still they don't have a very active running product facility. Like us, since 25 years, we are still talking. Nothing in fact. Can you imagine 2016, 2021, still Turkish Red Crescent is going to establish the plasma eligible for transporting to the Germany. This is the fact on the scene, but the reality is different. We have to show very simple way for politicians. We may say that, okay, you are, last year, you sent biologic waste, 100,000 liters of plasma. This you paid for the wasting, let's say $10,000. If you wouldn't send it to that one, you would get that amount of products. And that amount of products will be that amount of money. This is a different way of corruption or whatever you say. I don't know if you are agree, if the president is agree, we will make a small group just to think about and make a uniform presentation for the countries, small countries, to show them how they will make valuable of their biologic waste. Thank you.
Thank you. Maybe Leni, would you like to reflect something on this?
Thank you, Dr. Nuri. It's really nice you remembered my old colleagues in Finland. But that I said, it's 25 years ago, and now we are moving into a new phase. And we at IPFA would be really happy to. I was actually thinking when I heard your talks, especially Ranjeet, that we should try and help you in a certain forum, because you have the special problems in this special part of the world. And I think we have not only learned from the pandemic that plasma is important, but we have also learned ways to cooperate like this on the video. So it makes it much easier if we can also meet a little bit more often and keep the momentum on the discussions and not bring up the same item 1 year and then wait 1 year and then we talk about the same thing. But so we would be happy to collaborate in such some kind of think tank with you. That sounds very good idea.
Thank you, Leni. Amy, would you like to share your view?
Yes, thank you. Yeah, I agree with what Dr. von Bonsdorff said, but also I think we cannot emphasize enough the importance of the voice of the patient groups. I spent a lot of years working on Capitol Hill, and I recognize there's probably a much greater luxury associated with patient groups in the US and in Europe, just surely because of economics. But those patient groups are no longer regarded as sort of just the voice of patients telling anecdotal stories to policymakers. They're in fact data collectors. Some patient groups are developing, they have very sophisticated development arms now globally. And I know that if any local patient groups that are associated with those global groups will have a much greater say, I believe, with policymakers really than anything providers or industry has to say about it. And their voice really needs to be the tip of the spear.
Yeah, I think it's a very right way to think, because our approach has to be the patient centric, and they should be at the center of the whole storyline. And if we are able to talk to the regulators and the policymakers, it will make a huge difference in changing the scenario where we are today. And I do recall, my initial days of work in India when I returned back from the US and started my work. And I do remember meeting some of the regulators and doctors. And I do remember, meeting one of the leading hematologists in India, and he said, "Ranjeet, you are looking at this plasma business very romantically. You may not be able to marry it for a long, and you may, decide to go back to the USA. Don't close your bank accounts." And I said, "Okay," but I'm glad I stayed back and was able to do whatever I could. So I think with all this, I would say cynicism and the challenge which we face in the political arena, but there's a hope also within this space that if we push little hard, these politicians, they are difficult, but I think they are not impossible. And I think we just need to keep that hope alive, and we need to work together as a team, whether it is from A geography or B geography or A group or B group, doesn't matter. Eventually for us, we are working for the patient, and whatever help we get from any corner, we should welcome it. And I think there will be a lot of people who would be more than willing to come forward and help us. And I think this is the forum is a one example where I requested you to come early in the morning of hours of the USA, and you were so glad to came. I'm so glad you came and accepted. And same for Leni. It is just the last week I reached out to her, and I was feeling bad that I'm just reaching out at the end, but you were so gracious and considerate to. So I think this is the way probably we'll go forward.
Can I make a comment,
Yes,
Ranjit?
please. Yes, please, Navjot.
Yeah, as I actually talked in the beginning, let this webinar doesn't stop after 10 minutes or 15 minutes. Let it be a continuous process, you know. So here, three associations or three organizations are involved at this moment: PPTA, IPFA, as well as AATM. And we have got an anchor, that is Dr. Ranjit. So may I put a request forward, because you know this is the region, because which actually needs some sorts of, you know, concerted effort to push forward. It's not only fractionation, as I told you in the beginning. It's first we have to prepare components. India is a huge country. We have got almost 12 million units collections. We have got small countries. But if you see from percentage point of view, component separation is not very good. In India, it's probably 75%. In neighboring countries of this subcontinent is almost 50%. If you go to other countries, the figures changes. What I mean to say, probably if you really talk about a fractionation, so we can do this advocacy at least in these 20 countries where we have got our, you know, our country chapter. We have got country chapter is like a branch, you know. We have got a group of people who are AATM members, and those are actually they are from, you know, the country managers. They are working in the blood banks. So I request Ranjit to carry it forward, to make it a small group who can work to promote component preparations as well as followed by fractionation, both fractionation of the source plasma as well as recovered plasma. And we can start with advocacy. And in this regard, two WHO, I mean, region, we have got good context. One WHO region is CRO, and one WHO region is AMRO. So we have got context. I think they would like to join hands. Over to you, Ranjit. It's a proposal from our side.
Sure. Thank you, Navjot. And, I mean, it's good to collaborate with people with a different perspective, different insights, and also they will bring more value to the entire work. So I appreciate, and I'm sure, we would be more than happy to work with everyone who can contribute to the cause. I think everybody should be welcome for the cause. Cause is more important than anything else, I guess. Any
Ranjit,
questions from the audience?
Ranjit, can I
Yeah, please,
comment?
Ananda.
Yeah, very briefly, and I totally agree with what Dr. Nuri and Dr. Choudhary said, because the reason is from the manager's point of view, if you take up in this part of the world in blood transfusion services, the managers are aware, clinicians are aware, but when it comes to the authorities, they don't understand this very much, and it is very, very difficult to convince. And my proposal is to get an organization like WHO, as Dr. Choudhary said, to work together and using this international organization that whom we have met today, and make a effort through the WHO to come into the policymakers, politicians in those countries. Then it will work. At the moment, most of the people do not understand the value of that. They know from their budget so much of money is going out for the plasma products, but to make a halt or to make a production line going on, they have no plans and they don't bother it also. Thank you.
Thank you. Thank you, Ananda. Yeah, it's a very valid point, and I think I will share a very interesting story here with the audience that in late 80s and early 90s, when this hemophilia tragedy happened for the HIV thing, and all of a sudden, the government put a ban on production of local factor VIII way back in early 90s. And they said no more factor VIII produced in India. And because a lot of people contracted HIV and other diseases. So there was a blanket ban from 1988 to 1992, no factor 8 available. Of course, the import was not allowed. Locally, it was not available. So about 4,000 hemophilics were leading a very crippled life and they were dying every single day, either because of the hemophilia or because of the HIV and other challenges. But one fine day in 1992, the Chief Secretary of Government of India, his nephew was diagnosed with the hemophilia at 4 o'clock in the evening. And next day morning by 10 o'clock, the license was issued to get factor 8 to India. And this is the power of politics. We might deny it in one way or the other, but we also have to remember the change must come along with the social and political landscape both. It cannot happen in itself. And so there is a power of politics, and I think there is a political will required in making those change. So I think look at from 1992, the patient care which has improved in hemophilia in India and the life of hemophilics between 88 and 92. So I know some of the hemophilics, unfortunately, I lost my friend last month and he was a survivor of that tragedy. And the way he used to narrate the story to me, I mean, the tears will roll down your cheek what he has faced. So I think it's very, very important to consider that fact. Yes, we do need to work alongside with the agenda for keeping patient in mind. Any question from the audience, please?
Yes, Ranjit sir, Social sir, I had a question.
Yes, Sushil.
Yeah, good evening, Ranjit sir. Thank you so much for arranging this webinar. This is really value-adding for
You're welcome.
all of us. So yeah, my question is to the panel. Anyone can choose to answer.
Sure.
In very recent times, we see Canada is moving towards source plasma. I think this is a very strong case study. Do you think any other countries, this can can stand as a very good testimony or a case study for other countries to follow suit? So what are your thoughts?
Amy, would you like to take this question?
Thank you. I think that, yeah, and again, the development of plasmapheresis programs, we believe is very important, separate from and apart from just recovered. So I think this is a really good point. And sort of dovetailing on what Dr. Ajmani was saying as well, I think if you look at the UK right now, the UK really abandoned its plasmapheresis infrastructure because of CJD, and now is revisiting how to rebuild that infrastructure, whether and how. And of course, someone mentioned the pandemic and the sort of what we call the halo effect, or the good things that might come out of it. And one of those is that, so the UK, for example, had I think 20 some centers set up to collect convalescent plasma. And so that could be used to build their infrastructure. So yes, I do think that more countries will move to that model and should, in order to meet the demands of patients for these medicines.
Thank you. Thank you. Anybody else question? I guess there are no questions. So maybe I could request Ananda for his closing remarks and vote of thanks. Ananda comes from Sri Lanka.
Yes.
And he has been very active in our forum and has been a good friend. So Ananda, to you.
Thank you very much, Ranjit. It's a very important and interactive session, and I thank all the people. Now, if I take one by one, can I please thank Dr. Ranjeet Ajmani, who put everything together. He contacted the international lecturers, he contacted the AATM very efficiently, and also worked very cordially with our technical teams. And thank you, Ranjit.
Sure.
And then let me also thank the most important group, that's the lecturers. Can I thank Dr. Leni von Bonsdorff, the president of the IPFA, for giving us a fantastic lecture. And then we have
Thank you.
Miss Efantis, I'm sorry of my pronunciation, CEO of and the president of the PPTA. She contributed beautifully, and it was very interactive session. Then we have Ranjeet, of course, delivered the Asian side of plasma fractionation and the availability of plasma products. Most important group of people, that is the participants. We have got about 95 participants, so thanks goes to them. And last but not the least, our president and the executive council of AATM for guiding us and giving us the authority to go ahead with this important webinar in this very, very important field. We also have to thank Dr. Aikaj and Dr. Amit, our technical people from the ATM. They are our good members for putting everything together and making it so efficient. Thank you, Aikaj and Amit. So we are not going to close up. We are going to start from today. AATM together with the PPTA and IPFA, and we got to, as Dr. Nuri said, we got to work. We must use our brains as a think tank, and we must get this message across to the policymakers, politicians in different countries. And we need to impress the WHO to do that, in my personal opinion. And thank you very much, everybody who participated, who lectured, who coordinated. Thanks.
Thank you. Thank you, Ananda. Thank you, Amy. Thank you, Leni. Thank you, Nuri, and everyone here and audience. It was great, and I really sincerely appreciate your time and effort. And I hope it was useful for all of us. So thank you.
Okay, bye.
Thank you to you, Ranjeet, and thank you to.
Bye-bye.
Bye.
Bye.
Bye. Bye.
Thank you. Thank you.
Bye.